Your dentist just pulled a tooth, or is about to, and somewhere in that conversation you heard the words bone graft. And something in your brain immediately filed that under complicated, expensive, probably optional. I want to talk to you about that assumption, because the word graft sounds like a big deal. And the truth is, when we're talking about a simple socket preservation procedure at the time of extraction, it's often far less evolved than what most people picture. But here's what is a big deal: the timing. What takes one appointment to prevent can take 3 surgeries to reconstruct. And that's not a scare tactic, that's biology. Let's get into it. What's up, everyone? Dr. Eric Jackson here. Hope you're doing well. I've been practicing dentistry here in Downers Grove for nearly 20 years. And today we're going to go ahead and speak about something that comes up fairly constantly: bone grafting and socket preservation, why it matters, why it's done, and why the window to do the easy way closes faster than most people realize. If you didn't catch my tooth loss video, I'll link it below. But if you did, you already know that the moment your tooth comes out, your body stops maintaining the bone underneath it. That process starts within months, not years. And once that bone is gone, it doesn't grow back on its own. What a bone graft does, at its most fundamental level, is intervene in that process before it gets started. We fill the space with the material that guides your own bone to grow back into it. We preserve the architecture. We keep your options open. Here's something that most patients don't know about what happens to the empty socket after a tooth comes out. The socket is essentially a void, and your body, extraordinarily efficient as it always is, has a plan for that void. It wants to fill it. The problem is, left to its own devices, the body tends to fill that space with soft tissue rather than the dense, load-bearing bone that you need. The bone walls of the socket collapse inward. The ridge shrinks. 2 things happen, and they happen together. You lose width first. Studies have documented somewhere in the range of 25 to 50% of the ridge in the first year alone. And then you start losing height. The ridge gets narrower and shorter simultaneously. Why does this matter clinically? Because dental implants, which we're going to cover in depth in the next video, require a specific volume of bone to be anchored securely. If you don't have enough bone, your implant options are limited. And restoring that lost bone after the fact is significantly more complex undertaking than preserving it in the first place. A bone graft placed at the time of extraction changes that trajectory entirely. So let's talk about what a bone graft actually looks like in practice, because I think bone graft conjures up images that are more dramatic than reality. The most common version by far is socket preservation. We remove the tooth. The same day before you can leave that chair, we pack bone graft material directly into that socket. Depending on the clinical situation, we may place a membrane over the top of that socket opening. Think of it like a screen door. It keeps the soft tissue on one side, and it gives the bone room to grow undisturbed on the other side. When we do use a membrane, it's typically collagen. It dissolves on its own over time, and it's doing an important job. It's a guided bone regeneration barrier. But whether a membrane is necessary depends on the specific case. In many cases, we'll place a temporary restoration over the space, so you leave with a tooth in place, or at least the appearance of one. You go home, you heal, and over the next 3 to 6 months, something genuinely remarkable happens. Your own cells invade the graft material, use it as a scaffold, and replace it, slowly, methodically, with your own bone. That graft material is not permanent. It's a placeholder, a framework your body uses to rebuild. By the time we take a cone beam CAT scan, which I'm very fortunate to have right here in my office, and we evaluate that site months later, we're looking at the bone that's essentially your own. Patients always ask, what exactly is the graft material? And that's a fair question. There are 4 main categories. First is autogenous bone, bone taken from your own body, typically from another area of the jaw, or sometimes a hip or shin in larger cases. It has excellent bone formation potential. The trade-off, it requires a second surgical site. Second, and this is the most common in everyday socket preservation, it's allograft. Processed bone from a human donor. Before anyone gets uncomfortable with that, this material goes through extensive processing and sterilization protocols that make it safe and effective. It's been used in dentistry and orthopedic surgery for decades. The track record is excellent, and you don't need a second surgical site. The third is xenograft, bone from an animal source, typically bovine. Also, a well-documented history of clinical success, processed extensively, and it does not require a second surgical site. Fourth is alloplastic, fully synthetic materials, calcium phosphate compounds, bioactive glass, various formulations, man-made from start to finish. All four can produce excellent results. The choice depends on the specific clinical situation and what your dentist determines to be best for your case. It's not something to lose sleep over. It is something to ask about. Your dental team will explain exactly what they're using and why. This is one of the most important concepts of the entire video, so I'm going to slow down a bit here. There are two versions of bone grafting. There's prevention and there's reconstruction. And the difference between them, in terms of clinical complexity, number of procedures, healing time, cost, predictability of outcome, it's significant. Prevention is what we've been describing. Socket preservation placed at the time of extraction. One appointment, bone maintained, the ridge stays intact, your options stay open. Reconstruction is what we do for a patient who comes into us after the fact. Maybe the tooth was extracted years ago and nothing was done. The bone has already resorbed. Now we need to rebuild it before we can even think about an implant. That means ridge augmentation, restoring width to shrunken ridge. It might need a sinus lift. I'll explain that in a moment. In significant defects, it might mean a block graft, where a section of bone is literally taken from another part of the jaw and secured with titanium screws to rebuild the architecture. Think about it this way. Maintaining the foundation of a building is a routine part of construction. If you let the foundation collapse, then rebuilding it is a major project. The result can still be excellent, but it takes longer, costs more, requires more stages of healing, and inherently less predictable than simply keeping the foundation intact from day one. Prevention always wins, and socket preservation is the most direct, most affordable, most elegantly simple version of prevention that dentistry offers. A quick note on sinus lifts, because patients hear this term and it sounds alarming. Your upper back teeth, your upper molars, sit in an area of the jaw that is directly beneath your maxillary sinus. The sinus is essentially an air-filled cavity above the roof of your mouth. In many patients, particularly after upper molar extractions, the sinus floor descends and the available bone height for an implant becomes insufficient. A sinus lift procedure elevates the floor of the sinus very gently and places graft material in the space created beneath it. Over time, that material becomes bone. Then, once that bone has matured, an implant can be placed. It's a well-established, highly predictable procedure, but it's an additional procedure, additional healing time, additional cost. And in many cases, it would not have been necessary if a socket graft had been placed at the time of original extraction. The sinus descends because there's no longer a tooth root there to maintain the bone height. Preservation from day one can prevent that descent. Here's the part that often surprises patients the most. You don't have to know what you want to do before we graft. Here's how we approach it in our office when a patient is uncertain. We extract the tooth. We place the graft the same day. We put a temporary restoration in place. Then you go home, you heal, and over the next 3 to 6 months, you actually live without that tooth. You find out if it bothers you functionally. You have time to think, to ask questions, to research. And because we preserve the bone from day one, your options at the end of that healing period are excellent. If you want an implant, the bone is there for it. If you decide a bridge makes more sense, you've got a healthy ridge to support the pontic. If you ultimately decide to leave it empty, at least the neighboring teeth aren't collapsing into a sunken void. You made the smart move on day one, and you gave yourself the gift of time and options. That's the staging benefit. It costs the least and preserves the most. The specifics of who performs what, socket preservation, ridge reconstruction, sinus grafting, depends entirely on the clinical situation and what your dentist recommends for your case. And I'll be honest, not every general dentist has this training or the infrastructure to place bone grafts in office. It's actually pretty uncommon. I'm very happy to say that we do. We have the training, the surgical capability, and the team experience to handle socket preservation and other grafting procedures right here in this office when it's most appropriate for your case. For more complex situations, or if you ultimately decide you want to work with a particular specialist involved, we absolutely work with trusted periodontists and oral surgeons. But the point is, you've got options, and many of those options are available without bouncing between multiple offices. That's a genuine advantage, and it's something we're very fortunate to offer. Here's what I want you to take away. Bone is the foundation of everything. The implant sits in bone. The bridge sits on a ridge maintained by bone. Your facial structure is supported by bone. And preserving that foundation costs far less in time, money, healing, and complexity than rebuilding it after it's gone. If you watch my tooth loss video, you'll remember that chain reaction. Bone loss, shifting teeth, bite breakdown, joint damage. This is exactly where that chain gets stopped. A socket graft placed at the moment of extraction interrupts the cascade before it begins. Prevention always wins. And if you want to see exactly what happens once that bone is ready, when we're placing the implant itself, building the crown, restoring the full function of that tooth, that is exactly what we're going to cover in the next video. That's the one you're going to want to see. If this is a conversation you're ready to have, come on in. Let's put together a plan that actually fits your situation, your timeline, and your budget. We have options for every single patient. Jackson Family Dentistry, 2033 Ogden Avenue, right here in Downers Grove, Illinois. Give us a call at 630-963-6750 or find us online at jacksonfamilydentistry.us. New patients are always welcome, and we would love to take care of you. If this video was helpful, give it a thumbs up and hit subscribe. I put out content like this regularly, and I'd love to see you in the next one. I'm extremely passionate about modern dentistry, and I love discussing it with patients, so don't hesitate to reach out in the comments below. Thanks for watching, take care of yourself, and I'll see you in the next one. Bye now.